Hi, everyone. We'll just keep this informal. So they asked me to come and talk about adult epilepsy and kind of what causes it, treatment, all those kinds of things. If you guys have any questions in between, feel free to ask me to. Like I said, we'll just keep it kind of informal. So, when I get a new patient typically and kind of discussing what epilepsy is, epilepsy just means that there's a underlying risk for recurrent seizures. So patients actually are allowed to have one seizure in their lifetime. That sometimes patients have one and may never go on to have a seizure again. But for a good proportion of people where seizures can occur again, then that's what we call epilepsy, and where treatment is really necessary. That's part of where kind of I come in terms of getting history and information. There are many times that patients have a first-time kind of tonic-clonic seizure, but then when you discuss the case a little bit more and find out from them that in their history that they had some weird symptoms that they just never thought anything about. But upon hearing it, I think, oh, those are actually little seizures that you're probably having. And, that kind of information, again, guides whether or not we need to start treatment. And so, again, that's something where myself as an epileptologist oftentimes may be able to kind of pull out or tease out a little bit compared to general neurologists and things out there. And so, based upon that, we decide on medications and treatment. We may be getting further testing done, like MRIs, EEGs, and things like that to help support that. But ultimately, the diagnosis is a clinical diagnosis. So many times people will say, oh, but I had a normal MRI, I had a normal EEG before. How do I have epilepsy then? But many patients who have seizures, even frequent seizures, could by chance just have a normal looking MRI, normal EEG. Those things don't 100% rule out epilepsy. So really, again, a lot of the times the diagnosis is made by the clinical picture, kind of how often the patients are having the seizures, and kind of the description of them a lot of times is what guides us. And then from there, if we need additional testing to help support that, that's kind of what we'll do. Now, what causes seizures in adults then? And most people think of epilepsy as being, it's the children who have it, like they grew up with it, it's a genetic thing. That is a component to it. There may be some genetic kind of predisposition, but a lot of times we don't really know. There's something about the brain that changed during that time that might have caused seizures, or there may even be some structural abnormality that was in the brain and unbeknownst to the patient, and it only became active later on in life. There's even cases, for instance, where as a fellow, we saw this classic lesion that should have caused seizures in someone that was in their 20s or whatever, but they didn't start having seizures till their 50s. And you wonder, and you get a proper history and really find out from them, delve into, did they really not have seizures until later? And sure enough, that they didn't have seizures until later in life. And we don't fully understand the brain. We don't fully understand how all the connections work and things like that. But seizures can start and happen at any age. It goes from childhood all the way up to your 90s or even 100 years old, because and what I tell people is that in younger people, it's genetic causes are most common. In older people, it's some kind of damage to the brain, say from strokes, TBI, tumors. Those are the most common, but kind of everything in between is a kind of a mixture of some of those things. So we see the full gamut from as an adult epileptologist all the way from teens to kind of really old patients as well. So and then treatment, it really starts off with medications first. So there are now, I think, like 20 plus seizure medications out there. So my spiel to people is that my goal is to get you seizure free and hopefully not have any side effects from medication. There's really no point in someone taking a medication every day and dealing with these side effects when there's so many other ones that are available and potentially could work just as well and not cause side effects. So, there are many people who have been on certain medications forever and been doing well, but had, sedation or whatever from it. And those are cases, again, where I think us as epileptologists a lot of times can tweak some things and help things in that manner. That being said, medications is not the kind of sole treatment for epilepsy. Up to a third of patients are what we call refractory epilepsy, so meaning medications have not worked to control things. And this is a discussion I have with most people from the very first visit, because I don't want it to be a surprise 2 medication, 3 medication down the line that, medication's not working. So what I tell people is that about half of people get seizure control with their first medication. This is all based on studies that have been done over the years. People who fail that first medication, meaning they tried a good dose, they tolerated it, it wasn't because they stopped it because of side effects. If the first medication didn't work, you try a second medication, you get another about 15% or so people who get control with that one. And then really after that, the second, third, fourth combination or even combination of medications, it's been shown that the chances of another medication working at that point is less than 1%. So that's when we really start thinking about epilepsy surgery. As you just heard, that was a big part of my training as an epilepsy fellow when I was in Philadelphia. When medications don't work, and you're just kind of spinning your wheels, you still have all the risks with having the seizures. Falling and hurting yourself, if you're losing awareness, then, walking out into traffic, those kinds of things are still all risks. And then on top of that, there's also the risk for SUDEP, so sudden unexplained death in epilepsy, which again is also something that a lot of doctors don't talk to patients about, but and it's an important topic and it's an important risk to know about, because really getting seizures controlled is the best thing to minimize that risk. And so that's why we do think about surgery and even devices and things like that when medications haven't worked, because if there's a less than 1% chance of medications working in surgery, even with the risks that are associated with that, let's say are at worst 30%, at best case scenario is maybe 70, 80% chance of seizure freedom, why wouldn't you take that risk? So the equation really changes at that point in time. So again, that's something that I usually talk to patients early about, because again, we try those few medications in the beginning, but if it's really not working, then we're talking about starting the process of evaluating patients for that. And with all the new medications that have come out over the years, over the decades, really, that number of refractory patients hasn't really changed very much. It's still, even looking at kind of newer patients on all the newer drugs that have come out over the last, say, 10 years, that percentage is still about a third of patients that are not getting controlled by medications alone. So that's where, again, surgery may not make seizures go away, but we talk about it may make medications work a little bit better. And so, again, it takes a whole evaluation. And for instance, at HOAG and other epilepsy centers in the country, we don't take surgery lightly. It's not something you just kind of say, oh, this is where it is, we're going to cut it out. It's a whole process where multiple epilepsy specialists get together. And for instance, at HOAG, we have a consortium, as I was talking with Susan about, with us, USC, various other hospitals kind of in the Southern California, kind of Central California area, where every Wednesday we get together and discuss a case and discuss kind of what the next best steps is for that specific patient. And so getting different ideas, different thoughts on how to best treat an epilepsy patient before kind of even doing that. And then only once we do all that evaluation and once we discuss it with the patient and they say, okay, I want to go through with it, then it's meeting with the neurosurgeon and all this stuff. So it's a whole long process. But again, ultimately our goal is to get patients seizure-free. And seizure-free means 0 seizures, right? That's always the goal. It doesn't mean, oh, 1 seizure, 2 seizures a year, that's okay. To us, that's still, for instance, if patients are having big tonic-clonic seizures, still poses a risk. So our goal is always 0. If you ask any of the epileptologists here, our goal is always 0. So that's usually with a combination of, like I said, medications, surgery, again, where you can cut parts of the brain out, hopefully to try and make seizures better, or even devices that are kind of a newer thing and have really revolutionized how we do epilepsy treatment. So that's kind of my spiel that I give to most people who come in for their kind of first visit. And then, other things in terms of safety with seizures and, driving with seizures. Those are all things that you'll talk about kind of with the diagnosis of epilepsy. But that's just to start off. But anyone have any specific questions or things that from kind of what I just said that, yes?
You mentioned that when you're interviewing a patient for the first time that you ask them, symptoms that they might not have paid any attention to.
Mm-hmm.
What might those symptoms be?
So the question was kind of what kinds of symptoms might be things that we ask about. So really the brain controls everything. So symptoms of seizures can be truly varied. It can be anything, right? And so I was actually just talking to one of our nurses about how, I've seen videos of patients who do these weird things that you think could never be a seizure, but sure enough it is. And that's because, again, the brain does everything. And so for us, what we're looking for is really stereotyped symptoms or stereotype things that a patient might do. So if they're doing the same thing every time that and from that even going on to having a bigger seizure, that helps us to say kind of that is most likely a seizure. More common symptoms that patients may complain about or tell us about that maybe wasn't noticed before is, for instance, temporal lobe seizures, or which is the most one of the more common epilepsies. Patients can get a feeling of deja vu or get a feeling of sudden anxiety or, a sense of doom or, a butterfly sensation or rising sensation in the stomach. And a lot of times they may actually get misdiagnosed as panic attacks, for instance. I've had patients who came in, had a diagnosis for a panic attacks for years, and were having these every day, very short kind of episodes, and only once they had a bigger seizure were they really and then saw me, then we were like, okay, those actually may be seizures. And sure enough, when you start treatment with the medication, they get better. And so that oftentimes gives more information too. When you start treatment, do they get better? That they may actually be seizures. And so those are things that, again, sometimes I'm kind of delving into further and trying to get. If seizures are starting where your vision is, people may see flashing lights or even hallucinations. It's where hearing is, they may hear buzzing noise, things like that. So it really can be varied depending on where seizures are starting. So there's no formula that patients follow. Everyone is different. Everyone has their own type of epilepsy. And so it's just about getting some of that information and maybe even family being there to help provide that information, because patients themselves may not be aware of it at all, where once they lose awareness, they don't know what's going on. And so family or friends who see it frequently, they can give more information, and that's oftentimes very helpful. Yeah.
Have you seen people that have one type of seizure move to have another one?
Mm-hmm.
For instance, nocturnal seizures could potentially be during the day?
Yeah. So the question was, can patients have one type of seizure and move on to different types? And that definitely does happen. For instance, there are the genetic type of epilepsies, which the generalized type of epilepsies can oftentimes do that too. So, children who had blank staring spell, what we call absence seizures when they were young, grow up and then become teens and then start having tonic-clonic seizures or having myoclonic seizures, which is like just quick jerking type of seizures. So sometimes it can change in that way for the generalized epilepsies. But even with focal epilepsies, like I was just saying, many times it may just be this aura, a feeling, never going on to having a bigger seizure. That's all they had for many years. And then suddenly at some point they start having bigger seizures. And we don't understand why that is all the time. The brain and the networks in the brain change. They change with age. They can change with hormones. Women during with periods oftentimes may have increased frequency of seizures. Maybe after pregnancy, things can change. So as much as we think we know about epilepsy and know about the brain, there's a lot of changes that can happen that we don't fully understand. There are patients who are well controlled on medications for many years and may go on at some point to become refractory even. That happens as well. So, and different outside factors can also play a role in that, right? So if someone has a diagnosis of epilepsy and let's say suffers a head injury, then you're creating a new area of the brain that is abnormal and could potentially be a focus for seizures, and maybe seizures will change. Seizures may be, the symptoms of the seizures may be a little different. Sometimes people have multiple types of seizures. Patients that do have multiple foci of seizures may have different symptoms and complain of different things too. So that's where, again, just sometimes getting that information, someone who's seen these kinds of things before, an epileptologist, may be able to kind of tease that out a little bit more than kind of a general neurologist. So definitely if there's a question about seizures, medications, seizure control, all those things, then I do strongly advise patients to be seeking help from an epilepsy specialist in those cases. So, yes.
Okay. I've had 48-hour EEGs done,
Mm-hmm.
and it doesn't show anything, but I have seizures. I have 20 to 60 a month, and my primary care doctor just put me back on Keppra
Mm-hmm.
because I was on it when I first started having them in 2017. But after the EEGs show no activity, the neurologists don't want anything else to do with me. So where do a person like me go to from there?
Yeah. So again, I think when there is a question about diagnosis, a question about kind of what the best treatment is, sometimes, again, that does require different people looking at it, and again, where an epilepsy specialist may come into play. A 48-hour EEG doesn't necessarily rule things out, especially if you didn't have your typical seizures on it. Or also sometimes seizures where patients don't lose actually awareness or consciousness, EEGs may not show much, or if there's a lot of artifact from it, EEGs may mask or be masked from showing what it looks like. So there are many times that we as epileptologists look at a video or look at something and we're like, that's definitely a seizure, but the EEG doesn't show much, or it's hard to see what's on it. But we again make the decision based on the clinical picture, and again may need to kind of delve into further with other testing and things like that. That being said, there's also this diagnosis of what's called psychogenic non-epileptic seizures. So there are patients and epilepsy patients that also have those kinds of seizures, and also so there's, I think, a certain percentage that have have both. But there are many patients who actually have what looks like epileptic seizures and everything, and are debilitated by it and things like that. And but then when you do the EEG, the brain waves look fine. The brain looks healthy and normal. And then sometimes that diagnosis is often made in the epilepsy unit as well. What the cause of that is oftentimes some kind of stressor that happened sometime in life. It's not even something that happened at the moment that seizures started, when seizures are increasing in frequency, it's not always then, but it can be something that happened 20, 30, 40 years ago even that is coming out. And I like to say that it's the brain's way of releasing whatever tension or whatever stress that might have caused and was never really fully addressed. And sometimes, again, making that diagnosis is difficult, and especially when there's patients who have both, it sometimes can be difficult. So, but that's something that would require, more. It would ideally be monitoring that's done in the hospital in an epilepsy monitoring unit, because then it's longer than 48 hours, and then it's in a controlled environment where medications and things like that can be taken off and try to make seizures happen. Seeing what it looks like on video, which is not always possible with the ambulatory studies and things like that. So that, again, I think is where an epileptologist really comes into play. Yeah.
Yeah, 'cause they put pseudo-seizure, but then they told me to do all this,
Yeah.
go to counseling, go to psychiatrist. I've done that for 2.5 years, and nothing has stopped anything.
Yeah, and I will say that treatment for instance, non-epileptic seizures is not always 100%. Especially, there are studies out there that have shown the longer that patients have had it and not been diagnosed with it, let's say, the harder it is to treat, because it kind of does become ingrained in kind of the people's psyche and what they do on a day-to-day basis and things like that. But that also, again, is something, I think that diagnosis sometimes has to be more clearly made. And if an epileptologist or hasn't done it, then I would say I take everything with a grain of salt in terms of, what other monitoring and other neurologists have found. Because sometimes what they found, we find it may be incorrect, or even other epilepsy specialists may have seen something, but we see something different. So that, again, I think, it requires kind of further delving into oftentimes. Okay. Yes?
How often do you find, my husband has finally found a medication that is working.
Mm-hmm.
How often do you find that there needs to be a switch of medications or an adjustment, higher or lower, based on how long they've taken it? He's only been on it for a year and it works,
Mm-hmm.
but my worry is, will it wear off? Will he start to get immune
Yeah.
or get used to it?
Yeah. So the question was, how often do we need to change medication doses, and does it wear off or people's body get used to it? There are some cases where patients have what's called a honeymoon period, meaning initially when they start something, they have good control, but then after a few months or however long, it stops working, and even as you increase doses, it starts working for a little while and then stops working. Those tend to be the patients that, again, have more the refractory epilepsies, that medication haven't worked. For the most part, I would say when patients have found something that does work for them and it is controlling it for a long period of time, usually they don't need a dosage change or maybe minor changes only because something happened. But also the other side of it is, like I said, sometimes patients' brains and their epilepsies change and we don't always know why. Someone that was previously well controlled becoming uncontrolled, that does happen on some occasions too. Now, sometimes finding that one medication that happens to work can take a long time. It's unfortunately it is a bit of a trial and error in terms of trying medications. I wish I had a crystal ball. I wish I had a blood test that would tell me this one's going to work for you, this dose is going to work for you, you're not going to have side effects on this, but there's no such thing. So we just pick medications basically based on what we think would work best for that patient. Oftentimes, can we utilize that medication's other properties to help other things that the patient is dealing with? Or do we want to avoid certain side effects because that patient has a history. For instance, let's say someone has a history of depression or anxiety where they were hospitalized and things like that, then I would probably want to avoid the medications that might cause mood issues. I might choose something that has more mood stabilizing effects. If someone has cancer and is on chemotherapy, I may want to choose medications that don't really interact with other medications as much. Those kinds of things. So usually we're picking things in that way. It's not that we think one medication is significantly better than others. We really will choose kind of patient-to-patient kind of basis based on that. And again, there's nothing. There's no head-to-head trials between medications, unfortunately. So, all of them work about relatively the same. It's about more side effect profiles and things like that, and also cost and all those kinds of things come into play too. But usually, after medication, good doses of medications have been tried, like 2, 3, 4, even depending on the cases. That's when I'm really starting to think about more surgery. Is that something that we should be moving towards? Because again, rather than spinning your wheels and trying up to 10 medications, which we know the chances are pretty low of finding that one, I'd rather get that ball rolling, and in the meantime, still be trying medications or changes sometimes. So, yeah.
I've noticed over the last 5 years of my life that epilepsy for every individual is very unique, and the diagnosis is very unique. And it's taken many trials and errors and experiments and tests to nail down what is going on. And my experience, we had to be our advocate with the doctor as well.
Mm-hmm.
We had to be asking the questions and challenging why. And if you're not getting an answer that seems to fit, keep going back. And if you don't get the answers, try another place. We first started at UCSF, made it going to Stanford before the diagnosis came after 3 years of tests. And so my question is, what's your experience of how long it takes between your initial visit with a patient and when you really get to a diagnosis? Is it months or is it years or is it some time?
I would say for the most part, the diagnosis is made kind of in the office. So, like I said, the diagnosis of epilepsy is more of a clinical diagnosis. It's based on what the symptoms are and kind of taking everything as a whole. As much as, again, EEGs have been done, MRIs are done, they can be falsely negative, right? And so really, again, the diagnosis is made based on the clinical picture. Now, if there's a question about the diagnosis, like even if I have a question about the diagnosis or I want to prove kind of what might be going on, then that's where other things like the EEGs and MRIs and other testing come into play. Even that, though, it's not always 100%. For instance, I have a patient in the hospital right now, second week of monitoring now, because she's come in with multiple seizures and things like that, and we really don't catch anything while she's in the hospital. It doesn't rule out anything, unfortunately, even if it looks normal during that whole time, just because there are many times we look and see normal EEGs, and there, like I was saying, there could actually be underlying seizure activity that we're just not seeing on the outside, on the scalp EEG. So it can take sometimes a long time to kind of finally come up with a diagnosis, but it's case by case basis. So some people's epilepsies are pretty straightforward. Some people's are a little bit more complex. It requires sometimes more testing and more monitoring, for instance. And that kind of stuff just gives more information to us to kind of make that diagnosis. And as you said, it is important for you to be an advocate for yourself, because I will say epilepsy is a field that is not well understood by physicians out there, ED physicians, internal medicine physicians, even neurologists. It's kind of a mystery to some neurologists as well, because if you think about it, in neurology training, we get maybe a month or two of epilepsy training as a resident. That also depends on where you're doing your training. If you're at a place that is a big epilepsy center, you might have more experience and more exposure to it, versus if you're someplace that doesn't really have epileptologists, then you're not going to really get that exposure. But you're still a neurologist. You still go out there and practice, right? You're still treating patients with seizures. And so that's where there is a kind of a huge difference sometimes in terms of who's treating you. That's also where I think if there is a question about diagnosis, seeing an epileptologist is going to be is at least going to get you to a certain level of knowledge base, right? And even going to big places like UCSF and big centers, sometimes, they may miss things that other people will catch, or they may hear or ask something about history that someone else didn't before. So it doesn't mean that they're not good centers, right? And we're doctors, we're fallible too, and so, but sometimes having fresh eyes may help. And so, continuing to be an advocate for yourself and trying to get sometimes different people to look at it might be helpful. So again, it's case by case basis, I would say. Yeah. Any other questions? Yes.
My son has focal seizures and he's less than a year into this. He seems not to metabolize the drugs well. You heard that?
Yeah.
So it seems like he's over-medicated and under-medicated at the same time. It's a very fine line because he walks into walls or falls to the ground, but not from the seizure, from the medication. You run across it.
Yeah. So
It's such a delicate
everyone's different. Everyone's tolerance of medications is different. So there are some people who you have on the highest doses of a medication and they're fine. Some people you start like very minimal doses and they have side effects. So even if the level is undetectable in those patients, they may be having side effects, let's say. So there's no right or wrong answer in terms of medications in terms of that. And then there are some people who do metabolize drugs faster for whatever reason, like someone may be on, the lower dose of a medication but have a good level, but you may put someone on double or triple that dose and their level may be really low, and we don't fully understand why that is all the time. The other thing where I think an epileptologist has more experience and knowledge of is also drug-drug interactions. Patients may be on multiple medications where they are interacting with each other, and one medication is actually making one lower, or one medication is making the other one higher and making it toxic. Those are things that oftentimes I'm thinking about even when choosing a second medication to start or a third medication to start, for instance, where I want to try and minimize that as much as possible. So that, again, I think is something that working with your epileptologist, or maybe if it's causing side effects and the level is low, what's the point of being on it? It's probably a good idea to just switch him to something else. At least that's my opinion. So again, that's where an epileptologist may be helpful in those cases. Okay, yeah.
I can't say it, but we are.
So, yeah.
Do you see any connections with other neurological diseases like MS or Parkinson's?
There are some connections. It's not like a one-to-one, like everyone, that you have MS, that means you're going to have a higher risk of epilepsy and things like that. You can think of epilepsy as sometimes being a symptom of something else. So anything that might cause abnormalities in the brain. So MS could be one of those things. Parkinson's, dementia, stroke, tumors, all those things are causing damage to the brain or causing a structural abnormality to the brain. And so in that way, those patients could have seizures. Not everyone does. Again, that comes into play then where it's not that every stroke patient has seizures, right? And so there may be some underlying genetic predispositions too that we don't fully understand. So it's kind of a combination of all those things. There's also some patients who, rare cases again, that we're recognizing more as an epilepsy kind of community is what are called autoimmune epilepsies or autoimmune seizures. So patients who have history of MS or other autoimmune diseases could potentially be at greater risk for that, where antibodies are being created in the body and they're attacking the brain and causing seizures. And so that's a new and emerging field over the last few years, decades, where we're thinking about it more for patients who have refractory epilepsies and things too. So, yeah. Yes?
You mentioned something about driving. What kind of
Yeah.
instructions do you
Yeah. So driving is a state to state kind of difference in terms of how long you have to go seizure free before you can drive again. Even reporting that you have seizures to the DMV is all state dependent. So here in California, at least, it's a mandatory reporting state, meaning everyone who has a seizure and say they went to the hospital, saw a doctor, the doctor has to report it. And then you have to be seizure free for 3 to 6 months. It's a little bit of a gray area in that sense. How long? Who can go drive in 3 months? Who can drive in 6? That's more dependent on the doctor who's clearing you. Different states, it might be 3 months. Some were up to a year and now really have been changing the laws to lower that. So it really depends on where you are. And in terms of seizure freedom too, it's more, it can also depend on what type of seizures you have. So sometimes there are loopholes where if you're having all nocturnal seizures just at night when you're sleeping, then and none during the day, then they may still be able to clear you for driving during the day because obviously you're not sleeping when you're driving, which is bad enough as it is. Or if all the seizures that you're having now are only the auras where you feel something happening, but you're not losing consciousness, not losing awareness, or if you have a long enough aura where you can actually pull over before having a bigger seizure, for instance, sometimes there are little loopholes like that, but that's really something that would have to be kind of found out or been a consistent thing for a doctor to be able to clear for those things. For instance, I tell patients who had their first time seizure, and it was at night, out of sleep, and they say, but it was in sleep. But I can't predict if you're not going to have one during the day. No one can really predict that. No one can predict when your next seizure is going to be. So that's why these driving laws are really in place. Not only could you hurt yourself, but you could hurt other people, kill other people even. So that's why as a public safety kind of issue, the driving laws are in place. As hard as it is, especially here in California where public transportation is not as easy, the laws are in place for a reason. And another thing I usually tell people is that there's a huge liability side of it too. So as much as you would want to drive and may go against the doctor's advice in not driving, if that were to happen and say, oh, it's fine, I'm only on the back roads, I'm not going to get in an accident. But let's say you did and you happen to hurt someone, then ultimately it becomes a liability thing for the patient because no one can prove that you had a seizure during that time, right? And so I have seen patients who, for instance, were waiting court dates and things like that, and probably were going to go to jail because of killing someone on the road. So it's not a small matter, and as much as it is hard and difficult during those 3 to 6 months of not driving, overall in the scheme of things, I think it's a small thing. So if you've been told not to drive, I strongly recommend kind of taking, again, until we can get seizures controlled. That may take a while too, so everyone's a little bit different. So that's where kind of family support and friends and things like that really do come into play. And that also plays a strong role in terms of how patients do in terms of epilepsy and their seizures and things too. So. Yeah, so that's actually a very good question because it has been shown that epilepsy patients have a higher propensity for things like depression, anxiety, other mood disorders. I think it's up to 30% or so of patients can have mood disorders with epilepsy. So the way I like to think of it or tell patients is that you have epilepsy, your brain has abnormal discharges that are causing seizures. So in the same way, you can have abnormal chemistry that's causing things like depression, anxiety, and those kinds of things. So it's oftentimes something that I'm asking about at visits that, how's your mood doing? Or family is saying how they're doing. Not only because medications oftentimes have those side effects, But again, from an epilepsy standpoint, it's important because that can come up. And epilepsy is stressful. People don't know when their next seizure is going to be. People don't know kind of, what injury they may suffer and things like that. And so that in and of itself can sometimes cause people to feel depressed and anxious and things like that. And so it is a common thing. And when it's becoming kind of too difficult and affecting daily life and things, it really should be something that's treated. And so sometimes that's something that I'm starting myself or getting kind of psychiatry colleagues involved. And it's an important thing to treat because it's also been shown that patients with epilepsy have a higher rate of suicide, have a higher rate of kind of harmful behavior and things like that. So it is an important thing to screen for and to treat, I think. And, even within the kind of practice parameters that they give to doctors, that, that's something that they always say should be screened for. So, yeah. Any other questions? Actually, what time? Yes? I'm surprised it took a long time to get asked. So marijuana, this is actually, California is especially a common question, but elsewhere even, where it wasn't legal and things like that. So for a long time, we really couldn't say much because everything was kind of anecdotal evidence, meaning it was like the child who has such bad epilepsy, like seizures every day, multiple medications, nothing controlling it. Mom said, enough with this, I'm taking them to Colorado to get Charlotte's Web or whatever it may be, and they do remarkably well. And then it goes out in the news and everyone's excited about it. Oh, it's this miracle kind of drug. Why don't we get it approved and all that kind of stuff? So that was what it was for a long time. But as epileptologists and doctors, we realized that's just a small part of the story. There are many patients who you never hear about that actually didn't do as well or actually did worse with it. And we're actually finding out more about it because now there's a company who actually makes a FDA-approved drug for epilepsy. And you'll probably see them out there too. And now that we have something that is controlled, meaning what you're getting every single time, rather than what you get out in the dispensaries can really vary. And they've done studies on this where they take drugs and test it, and you see stuff in there that they don't advertise, or you see that the content is a little bit different than what they say it was. You see kind of all this variability, even in batch to batch of the same product. And so because you don't know what you get every single time, you don't know how patients are going to do with it. You can't really make a connection with how epilepsy patients do. So now that there is a controlled medication that we know what you're getting every single time in terms of purity and all that kind of stuff, and we're seeing that it does help epilepsy, but it's not this miracle drug, that there are patients that do well on it, there are patients that don't do well on it, and part of that is because of drug-drug interactions that we didn't really know about before. So many of the patients, for instance, who did well on it, it might have been the fact that their clobazam level increased threefold when on the cannabidiol. So which one was it? Was it the drug or was it that another drug level increase, right? It may be a combination of both. And so that's stuff that we're now learning about and knowing about more. So in terms of who I recommend CBD to, it's right now only approved for patients who have this specific type of genetic epilepsy. So it's hard to get for adults who have focal epilepsies and things like that. Hopefully down the line that will be something that gets studied more and gets approved in terms of for patients. But I usually, in terms of going to dispensaries and things like that, will reserve that for patients who have really tried everything else. They've tried multiple medications, tried surgeries, that's even failed, tried devices, and really seizures have still been a problem. Then, for me, what's the harm in trying, even from the dispensary, or trying to get the insurance companies to cover this drug that is not yet approved for their type of epilepsy, but I have all this evidence to show them, hey, all these things haven't worked. Like this is kind of one of our kind of last ditch efforts, or one thing we haven't tried yet that's different. And a lot of times insurance companies will actually approve that and will try it, and some patients do well. And so it really is case by case basis in terms of that. But those are times that CBD, I would say, I would consider in adult patients. Or, again, in the adult patients who are now growing older from that childhood epilepsy, that genetic epilepsy. Many of them are living longer now and becoming adults. And so oftentimes we'll be trying the drugs in those patients too. So, yes?
Okay, so I'm just wondering if you've noticed any correlation between a person's diet, sleep habits, maybe not CBD oil, but smoking pot
Mm-hmm.
at a younger age. Do you see any effects on that?
So lifestyle and stuff does come into play sometimes. So sleep habits are important because we know that sleep deprivation can lower the seizure threshold. So normally, if your brain is having abnormal activity, but your threshold is above a certain level, then it's not going to cause a seizure. But if you have things like sleep deprivation, certain types of medications, for instance, getting sick, all those things can lower the threshold enough where seizures can occur. So lifestyle and stuff like that is important, getting good rest, consistent rest, all those things. Patients will often say when they have sleep deprivation that seizure can occur and things like that. So that's where that does come into play. Other lifestyle stuff like smoking, marijuana, oftentimes I'll tell people, again, you don't know what you're getting all the time in the dispensaries. You don't know what's in it. You don't know how that's necessarily affecting the brain, affecting drugs. But also there's some animal models to say that high THC levels, for instance, can provoke seizures. But whereas now there's studies being done in terms of can THC and CBD, some level of it actually be synergistic? But we don't know that stuff yet, right? And so it's what I say is, since we don't know, and if it potentially could be causing harm, probably should be just something we take away, right? And if it could be potentially making seizures occur more frequently or medication is not working as well, like why would we continue it? So that's where, again, that's kind of just the discussion I have with patients. They may say, oh, but I need it for this and that. If that's the case, then I will try to recommend maybe switching to more higher CBD kind of products, things like that too. It's the epilepsy and treatment of epilepsy is a relationship. It's not something I say, this is what you do. I work with the patients on what works best for them. Side effects wise, taking the medications itself, like, is it too hard for them? Is the pill too big? Those kinds of things all come into play. People sometimes require liquids. Can you crush your medication? Those are all things that do come into play and really, have to work with the patients on. Or sometimes if compliance is an issue, sometimes even finding daily dosing medications versus twice a day, 3 times a day dosing. Like studies have shown that daily dosing compliance is a lot better with that. So those are all things that, again, we have to work with our patients on. So it's a conversation, it's a dialogue between myself and my patients. So, if it's not working for you, then we got to find something else. Diet, for instance, there is what's called the ketogenic diet that can help with seizures. Again, it's like a drug, actually. Some do well, some don't do well. It's a very restrictive diet, so in adults it's very hard to keep up. So in children, for instance, who are developmentally delayed and you can control everything, then it's easier. But even then, something as simple as sunblock that has, like, let's say sorbitol in it can throw off the whole diet. So you got to be really careful about what's in it. So it's a very hard thing to keep. There are many patients that, for instance, children who are on it and do well, and that's great, but in adults it's a lot harder. Sometimes we will try what's called a modified Atkins diet, which is a little bit less restrictive than the ketogenic diet, but it's not something I would necessarily recommend for patients just off the bat. It's really when other things have tried, and really with the help of a dietitian that I would be doing it. So.
Is there something they should avoid, like sugar, starches?
Not necessarily, yeah. And everyone's seizures are different, so I can't 100% say that something isn't playing a role, but for the most part, there's not anything from a diet standpoint that would be changing that. So I think they're telling me it's over, but I'll stick around outside if anyone else has other questions. Okay.